established. And then we treat the mice for a month with either ADI-PEG20 weekly, or vehicle, or cytarabine chemotherapy, which is the standard of care at the standard doses, or both cytarabine and ADI. And we first tested the blood, and we looked at plasma arginine levels to ensure that ADI can deplete the mice plasma of arginine. This is the arginine level here, this is control, this is mice treated with cytarabine, and you can see that the ADI-PEG20 is effectively depleting plasma arginine, and the same is true in combination ADI plus chemotherapy. And as you might expect, citrulline levels go up with ADI treatment and with combination, which is as we expect. So the plasma arginine is broken down by ADI-PEG20 to citrulline, as we know. And we also looked at the bone marrow to see what impact there was on the percentage of human leukemia cells in the bone marrow of these mice. And I should just stress at this point that the 6 samples we tested all had a poor genotype or karyotype. So this is the risk group, and for 2 of the 6 samples they had poor risk. These patients do really badly, but even for the intermediate cytogenetic risk group, we looked and they have poor risk point mutations. So this FLT3 gene is an adverse mutation. So if you have the ITD, your outcomes are very poor. And again, so the combination of the karyotype and the genotype in all these 6 cases were poor risk. So we were testing the ADI against some tough AMLs. And this is the result from one patient. This is the bone marrow percentage of leukemia. Here is the control, which shows you about 90% of the bone marrow is made up of human leukemia. Cytarabine chemotherapy is working effectively. The ADI is less effective in this instance than the cytarabine, and the combination shows similar efficacy. But this varies from this varies from patient to patient. This is another patient. Here the control shows about just over 30% of the bone marrow is leukemia. There is a small reduction with cytarabine and a greater reduction with PEG-ADI, and an even greater reduction with the combination. And what we saw is when you look at the responses in vivo, with the standard chemo, 4 of the 6 respond. With ADI, 3 of the 6 respond. But with the combination, they all show a significant reduction. So there appears to be some synergism here. And I'll just give you another example of that. So this looks like true synergism here, i.e. cytarabine has no effect compared with control. ADI-PEG20 has no effect compared with control. But you combine the two, the ADI-PEG20 and the cytarabine, and you get a significant reduction in the leukemia burden. And we observe this both in vitro and in vivo, the synergism. This is an example of the bone marrow full of AML cells. Most of the AML cells in this bone marrow, most of the cells in this mouse bone marrow are AML. This was from a control-treated mouse, and this is from a mouse treated with ADI. And you can see regrowth of normal hematopoiesis. The arrows indicate megakaryocytes, which are the large platelet-producing cells. And so, in the mice treated with ADI, not only got rid of the disease, but you've also allowed regrowth of the normal hematopoiesis, which is absolutely critical. And when we look at ASS expression in the mice, again here we're staining with a brown stain so that leukemia cells do not express ASS1. This is in the mice treated with control. Whereas in the mice treated with ADI and we killed off the leukemia, you can see the normal hemolytic cells expressing ASF1. And we think that's at least one of the reasons for the differential response, i.e. the leukemia is more sensitive to the ADI than the normal hematopoiesis. So this leads us on to the clinical trial proposal, and what we are suggesting is testing the standard of care low-dose cytarabine for older, less fit patients with, in combination with ADI PEG20 as an early phase trial. As I mentioned before, that the low-dose cytarabine shows improved survival compared with best supportive care, i.e. blood transfusions and hydroxycarbonate for chemotherapy. So given that we've demonstrated that cytarabine is synergistic with ADI PEG20 in our preclinical testing, we would like to test the two together in less fit older adults with AML. And we're proposing a phase 1 trial with this low-dose cytarabine twice daily for 10 days with PEG-ADI weekly, starting at 18 milligrams per meter squared and later to 36 milligrams per meter squared if it's tolerated. And we'll look at this group of less fit older adults who do very poorly with standard treatments, in particularly those who are relapsed and refractory following low-dose cytarabine or hypomethylating agents, or those with adverse risk AML who can't receive hypomethylating agents. And the primary aim is to assess the tolerability of this combination. Thank you. That's the end of my talk.
Thank you, David. So I'd like to also just add the work we are doing with AML. We actually have a phase 2 AML study with ADI as monotherapy initiated in Taiwan. So it was led by蔡慧珍医生、陈立忠、陈彩玲、国卫院跟陈大。So we have completed the study already. 21 patients enrolled into the study. We actually have 2 patients that complete response. So the red blood cell, the white blood cell, the platelet counts all become normal, and 1 patient, they call the cytogenetic complete response, CCR, so that means the chromosome even went back to normal. We have prepared the paper for publication, it was sent out. So halfway through the study, MD Anderson became very interested in the study, so they participated. So it was actually a study led by Taiwan, but then a large cancer center, MD Anderson joined the study. The paper we published together with authors from Taiwan and MD Anderson. So data they presented here show that AML's future probably will be not just at using ADI, we can combine ADI with cytarabine, and then we're hoping for even better results with the new study, which we already have the protocol ready, we finally have it finalized, and John will present it, so we would move forward with that. So, anybody has any questions with David's talk? Yes.
Very nice presentation. So, in terms of the ASS1 high, ASS1 low in AML, are the ASS1 high better prognosis, or we don't know that?
We looked to see if there was a correlation with ASS1 expression in their cytogenetic risk group, and if there wasn't, so it was spread across the conventional risk groups.
And the CAP1 data, so I'm not sure, were any experiments done with the combination of ADI with the CAP1 inhibitor together?
No, I think the CAP1 inhibitor is might be fairly toxic. We weren't proposing to do a combination study.
No, I was just thinking in vitro whether there was anything that suggested it was more effective.
we haven't looked at that.
Okay. And the third one, I know we discussed this before about the platelet issue, and some people have concerns about intramuscular injections in AML. What cutoff are you proposing for the study? I know in TRACK we have a 50 count for platelets as our threshold for giving IM ADI.
I wouldn't propose a cut-off at all because most patients have profound thrombocytopenia at diagnosis, but I would propose platelet transfusions on the day of injection for those with low platelets to prevent that problem.
Any other questions? No? Okay. Thanks. So before the lunch break, John Bomalowski would summarize what we have learned, the data from the clinical trials. So the second part of John's talk will be in the afternoon about future planning, and then this part is for summary. So John is waiting for introduction. So you guys have seen John before. He's our VP of Medical, Executive VP of Medical Affairs. John has started working on ADI since 1990. He helped form a company, Phoenix Pharmacologics, 1996, over in Kentucky. And I've been a pleasure that I've been working with John since 2003.
Thank you again, Warren. Pleased to be able to talk about what has been going on clinically. You've heard some wonderful talks this morning that highlight where we've been, some lessons learned, and also where we would like to go. This is just an overview of the multiple studies that have been performed with ADI. As one can see, that there's been a number that have been performed with monotherapy.